In a second, I'll get into the modelling itself, but first I wanted to spend just a moment talking about the data that supports the modelling. The department has access to very detailed data about every MBS claim. This includes information on the patient, such as their concessional status and many other things, and about the service itself, whether it was bulk billed or privately billed, and if it was privately billed, how much a patient was charged, how much they received in MBS benefits, and their residual out-of-pocket costs. We are also able to attribute claims to GPs and GPs to general practices where that practice participates in the Practice Incentive Program, PIP program. This allows us to build an income model for over 6,600 general practices in Australia, and that's what we've done here. This particular example is of a mixed billing practice in a metropolitan area. In the 2025 calendar year, this practice bulk billed just over 75% of its services, received $670,000 in MBS benefits for those services. It received an additional $260,000 in bulk billed incentives for services that were bulk billed to children under the age of 16 and concession card holders. This practice privately billed 25% of its services. In total, they received $275,000 from patient fees. Patients who were charged a fee then received a total of $160,000 in MBS rebates. This becomes important later, so I've put a box around it there. So GPs at this practice earned revenue of around $1.2 million from GP non-referred attendance services in 2025. Important to note, this doesn't include any revenue generated from non-GP NRA services, such as procedural items, as this wouldn't be counted towards the bulk billing requirement of the program. Over the next few slides, you'll see that we adjust the current revenue to consider the positive impacts of the expansion of eligibility for bulk billing incentive items to form a baseline income for every practice. We then simulate the revenue each practice would make if it joined BBPIP and bulk billed all of its services. If that income is greater than the baseline income, then the practice is deemed to be financially better off joining BBPIP. As promised, the next step is to adjust the practice's current income to account for additional revenue from expanding eligibility for bulk billing incentive items to all Australians. To do this, we find the number of GP NRA services that GPs at this practice bulk billed to non-concessional patients in 2024, multiply that by the average bulk billing incentive rebate for that practice. This accounts for the practice's service mix and their location. This practice will make an additional $125,000 from bulk billing incentives due to the expansion, and will add to their existing revenue to create a new baseline revenue of $1.33 million. And this baseline is the comparison we use going forward. It's also good to note here that this doesn't factor in any changes to behaviour. This is just the exact number of services bulk billed for non-concessional patients last year. So now we begin to simulate whether joining the BBPIP and bulk billing every service will make this practice financially better or worse off. The first step here is to remove all patient fees, which in this case is $275,000. The next step is to reattribute the $160,000 of MBS rebates received by patients for privately billed services to GP, who will now bulk bill these services and receive the benefit directly. These newly bulk billed services will also attract a bulk billing incentive payment. Here we've multiplied the number of privately billed MBS services by the practice's average bulk billing incentive to drive the value of these incentives. In this case, it's $105,000. This brings the new income to just below the baseline revenue we're comparing it to. In the last step, we add the 12.5% BBPIP incentive payment, which in this case, very coincidentally, is also $105,000. This brings the overall new revenue for the practice to $1.25 million. Worth noting that the 12.5% BBPIP incentive payment is calculated on the value of the MBS service claimed before the bulk billing incentive is applied. So if you do a level B for $42 and then BBPIP is 12.5% of that, rather than 12.5% of level B plus bulk billing incentive. So as you can see, this practice is $95,000 better off joining the BBPIP, and it's $220,000 better off overall. Importantly, its patients will pay a total of $115,000 less in out-of-pocket costs. While this is a total income model, we've also modelled at the individual GP level and have considered several income and incentive split scenarios. This will have an impact on the modelling, but it's mostly the edges and whether clinics will be financially better off or worse off, and in the distribution of funding between GPs and clinics, where it's more important. It's also worth noting that services outside of GP NRA, mostly procedural items, electrocardiograms, other antenatal attendances, do not count towards bulk billing requirements of BBPIP and can be privately billed. And we've got a list, obviously, of services that are eligible there. If you bill a service that's not in that list, then it's not required to be bulk billed as part of the program.